All right. I want to welcome everybody to our third community webinar. The College of Human Medicine has been doing these webinars as a way to reach out to community members, talk a little bit about the science that has been going on at the college and surrounding the COVID-19 pandemic. Most of you no doubt have been following the news and know that we are in the midst of an increasing number of cases. In many cases also an increasing percentage of positivity in testing. And in my conversations with our counterparts or our hospital partners in Lansing, Grand Rapids, and Marquette, I know that cases in the hospital are increasing, as is the ICU burden. So we are clearly in the midst of something that's different than what we were dealing with this summer. In fact, at some of those institutions, they are now busier than they were in the spring. And some institutions have been transferring patients out because they are at or over capacity, especially from ICU care. So a large part of dealing with challenges like this, one part is preventing it, but another is potentially treating the people who have it. And as you deal with diseases, those are two of the core issues that we deal with in public health and medicine: preventing their spread and dealing with them when people have them. And this particular webinar is really focused on that second piece, using convalescent plasma or serum to treat patients who have COVID-19. And we have two wonderful panelists with us today. Dr. Nigel Paneth, who's a pediatrician and epidemiologist, joined Michigan State in 1989 to develop the epidemiology program, which then grew and evolved into the Department of Epidemiology and Biostatistics. His major research interest over the course of his career is the relationship of factors in pregnancy and around birth to neurodevelopmental disorders in children. And since March of this year, he has been part of the leadership team of the National COVID-19 Convalescent Plasma Project. And their website, which is ccpp19.org, is hosted by MSU. A considerable amount of research has been conducted by this group on the effectiveness of convalescent plasma, and some of the findings of that work will be presented as a part of this webinar. Leanne Whitekamp is a clinical pathologist. She's board certified in transfusion medicine. And Dr. Whitekamp has been senior medical director for 25 years at Vercetti Blood Center in Michigan. They were formerly Michigan Blood, and which was founded in 1955 and based in Grand Rapids. They provide blood products and services for more than 40 hospitals throughout Michigan. Vercetti is a fusion of donors, scientific work, and precision medicine, working to save lives in their communities. They're headquartered in Milwaukee, Wisconsin, with locations in Illinois, Indiana, Michigan, Wisconsin, and Ohio. We are delighted to have these two with us, and as the interim dean at the College of Human Medicine, we're honored to have Dr. Paneth and Dr. Whitekamp here to share with us. So with that, I believe that Dr. Paneth is first up. And so as he makes his way from the on deck circle to the batter's box, Dr. Paneth.
Yes. Now, first of all, are the slides showing at this moment, or do I have to do, or someone do something?
You're going to have to share.
Okay. Now, the difficulty here. Oh, here, I can get to that. Okay, share screen. Are you seeing it now?
Excellent. We are indeed. You are in.
Okay, so thanks everybody for coming to this community webinar, and I'm going to talk to you about convalescent plasma and try to contextualize it as a component of passive antibody treatments that we have available to us in medicine, and try to explain some of what we do and also some of why we think it's an effective treatment as we search around rather, desperately for appropriate treatments for COVID-19. Oops. Oops, now what's going on here? It doesn't want to operate. Here we go. So first of all, there are three forms of passive immunization available to us. And I want to distinguish passive immunization from active immunization. Active immunization is what happens when you get a vaccine, and vaccine stimulates the immune system for you to produce your own antibodies, and you have what's called immunologic memory. If you encounter that same antigen that's in the vaccine, and presumably also in the disease you're trying to prevent, 5-10 years after the vaccine, you should respond appropriately, form antibodies, and not get sick. Now, passive immunization is an older technique, and it involves giving preformed antibodies to a recipient to prevent or to cure disease. And passive immunity only lasts for a short time, a month or two at best. We have 3 forms of passive immunization: hyperimmune globulin, monoclonal antibodies, and convalescent plasma. And I'll go through them quickly, one at a time, so you will know what it is we're talking about. The oldest of them all is hyperimmune globulin. Believe it or not, this technology was first written about in 1890, 130 years ago, by Emil von Behring, who won the first Nobel Prize ever given in medicine in 1901. And he found out that animals, if you injected them, if they recovered from disease, you could take from their serum a substance that seemed protective. And he later showed that this was an antitoxin. He worked with 2 organisms that create toxins, diphtheria and tetanus. And by creating an antitoxin, an antibody to that toxin, you could really, really improve people's chances of surviving diphtheria, especially. It's a terrible childhood disease. Now, how did they, but they had to produce in large amounts these antitoxins to get these little vials you see here. How did they do that? Well, fascinatingly enough, they used large animals. So, for example, you would grow that bacterium in a test tube in the laboratory. You'd inject it into a horse, because a horse is large enough to make a lot of antibodies. Sometimes cows were used, but lots of them were horses. There's a report of one horse that produced enough diphtheria antitoxin to treat 30,000 children, believe it or not. They kept getting it, getting out of the horse. And they would collect the blood from the horse. They would separate out the antitoxin, make a medicine out of it. This was all very well, but horse serum contains all sorts of stuff we don't really want to have. And there was a disease called serum sickness. So nowadays, when we make these passive antibodies, these hyperimmune globulins, we actually take them from human beings, not from horses. And we have companies that are called plasma fractionating companies that take, that distill down the antibodies that are found in plasma, and particularly focus on people who've had the disease of interest. So there's a lot of antibodies. And then it's concentrated, it's manufactured, sterilized, cleaned, and given either as an IV product or as an IM intramuscular shot. And these are some of the diseases for which we have currently hyperimmune globulins on the market. Probably best known is the prevention of hepatitis. When there's an outbreak in your community, we give people the hepatitis immune globulin and they're protected for a while and with an exposure. In COVID-19, currently, there is a coalition of plasma fractionating companies who've agreed to merge resources and create a generic hyperimmune globulin product derived from patients. The product has been made. The group, by the way, is called the COVID Plasma Alliance. There's their website, I listed here. They initially involved 6 companies, 7 companies now, it's up to 10 or 11 companies, and they've all agreed to put their differences beside them and really work on one singular product. And but the trial is only just beginning now. Perhaps it's maybe a week or 2 old, and it's supported by the Gates Foundation and NIH. Okay, option number 2 for antibodies you've heard a lot about is the monoclonal antibodies. These were developed about 45 years ago by Kohler and Milstein, who received the Nobel Prize for this work. It involves fusing an immortal cell. This is done in the laboratory, such as a myeloma cell, cancer cell, with an antibody producing white cells to get this continuous production of a single clone of antibodies. And it's historically mostly been effective in cancer and autoimmune disorders. And we only have just a few for infections, respiratory syncytial virus, anthrax, and Clostridium difficile. So it's really kind of a bit of a new thing to try monoclonals on infections in people. But as you probably know, because it's been much in the news, two companies, Eli Lilly and Regeneron, are developing monoclonal antibodies right now, and they're conducting human trials. And in fact, Eli Lilly has just published the first result of a phase 2 trial and has shown that its monoclonal antibody is effective in reducing viral load and perhaps visits to the emergency room in outpatients. These are people who are mildly ill, not in the hospital. It's not a full trial, but it's a start. But unfortunately, they have an inpatient trial that has just been stopped for lack of effectiveness. So this would seem to work better in mild illness at present. The Regeneron product has not published any data. They've made some claims in news releases, but they haven't published anything. Now, as you probably know, each of these products has been used in just one patient. Outside of the clinical trials that are going on now, the Regeneron was used for President Trump and the Lilly monoclonal antibody in Governor Christie. I believe the FDA has now authorized compassionate use of these antibodies, and you have to directly apply to the FDA one patient at a time. Now I turn to the subject that we've been working on, convalescent plasma. So there's a big difference between convalescent plasma and the two forms of antibody treatment I've just spoken of, in that it's not manufactured. You don't have to go through a laboratory process. It doesn't take months and months to create this. You get plasma from a sick patient and you deliver it right. A recovered patient, and you can use it in a sick patient. So the advantage of convalescent plasma, and the reason a lot of doctors got excited about it, is you didn't have to wait. You could use it in the early stages of an epidemic. And by the way, this too, like hyperimmune has a long history of success, especially in bacterial meningitis, pneumococcal pneumonia, and also, interestingly enough, in the 1918 influenza. There are learned papers reviewing the data from then, arguing that convalescent plasma use was effective. You get convalescent plasma, someone comes to a blood bank, such as the one that Whitecamp works in, and it's obtained by plasmapheresis, a process which returns the red cells to the donor, so you can give much more often than you would when you're giving blood. And in fact, you can have a donation that might serve for as much plasma for a couple of patients, and you can come back even every few weeks and maybe more often than that and do it. Some of you know Mona Hana Atisha. She got COVID in England in March, and she has donated plasma 3 times that I know of, maybe more. So a lot of physicians, including myself, got energized by a paper that appeared in March in the Journal of Clinical Investigation by Arturo Casadeval, who I know quite well, and Lisan Perovsky, who I didn't know then, arguing that since we have no other treatment for COVID-19, we might as well try using convalescent plasma because it's got a good track record. And Arturo also wrote that a little before that paper came out in the medical journal, an op-ed in the Wall Street Journal, in which he told a story from the 1930s of a measles case that occurred in a boarding school. And the school doctor took blood from that first child who had measles and gave it to all the other boys in school, and nobody got sick. Just to give an example of probably much the same principle that we're talking about in convalescent plasma. And then one of the more remarkable things I've ever witnessed in medicine is just people came together, hundreds of people, word of mouth, emails, and a group was formed, a leadership group with doctors mostly at Hopkins, Mayo, Einstein, Washington, and MSU. And we called ourselves, maybe a little bit bragging, the National COVID-19 Convalescent Plasma Project. And as Aaron just said, we have a website, CCPP19. I'll show it to you in a moment. We began to have large-scale meetings, hundreds of people on the phone every Friday. And then everybody was taking on a different role, and MSU got assigned to create the website because I had the big mouth and had to talk about we need communication. So he said, good, make a website. And I know nothing about making websites, but MSUIT and also Amazon Web Services, who came in to help us, saved my skin and really did a fantastic job. They donated time, Amazon Web Services, and we put up a website in less than 48 hours on March the 26th. And you can see our website. This is it, just ccpp19.org. And it's hosted it's hosted by MSU, but we decided not to make it an MSU EDU, but to make it a .org. So it's a little bit independent from MSU supervision. But I couldn't resist putting the little logo of our Department of Epidemiology in the corner. And there's a chat box you can ask questions. And we try to be helpful to provide as much information as we can about convalescent plasma, any aspect of it, to both providers and to the world of patients, or families of patients, or people in the general public. So this is our group of 7. 4 of us are infectious disease physicians. That's Arturo and his colleague Shmuel Shoham at Johns Hopkins, Lisan Perovsky, who used to work with Arturo at Einstein, and Jeff Henderson at Washington University. They're all 4 infectious disease physicians. And Mike Joyner and me are kind of been long writing together, and he's an anesthesiologist, I'm a pediatrician, and God knows why we're in this mix. And then we really needed a transfusion medicine specialist like Leanne, and we took Brenda Grossman of Washington University, who's absolutely wonderful, a transfusion medicine physician. And then, just as we were getting organized, an amazing thing happened. On April the 6th, the FDA announced an expanded access program for convalescent plasma. And they decided to do it jointly with the Mayo Clinic, which is really where Mike Joyner comes in. So let me review with you the 3 consecutive authorizations of use of convalescent plasma at different stages of this pandemic by the FDA. It is an experimental biologic product. It's not been used before. So it has to be approved by the FDA Division of Biologics. And on March the 22nd, FDA authorized the use of convalescent plasma for compassionate use on a case-by-case basis. They got so many applications, and you had to fill out a 4-page form for each patient, and we had to wait for an answer on approval, that they decided to make it expanded access, but under the aegis of a study. So they worked with the Mayo Clinic to say that anybody who gets convalescent plasma, it has to be an inpatient, and you have to register the patient with this, in effect, a registry at the Mayo Clinic. And, and Mayo agreed to coordinate the study. And that was the only way you could get convalescent plasma until, these 2 ways, until August the 23rd, when the FDA announced its emergency use authorization, which means that now the EAP wasn't needed. Now anyone could give plasma to any patient in the hospital. They felt that the data we put together between April 6th and August 23rd was enough to say this is a product that can be used at least in inpatients and at least during the duration of this present pandemic emergency. So the Expand Access Program was a single-arm study. Everybody in it was receiving treatment with convalescent plasma. There's no way to compare to controls, although we've done some things to try to make that happen, but that wasn't part of it. And it was approved by the Mayo Clinic IRB, and I think one of the reasons FDA went with Mayo is it was approved on the same day that it was proposed. How many IRBs can do that, friends? I wish we could. And contract from BARDA. This is that small agency, or not well-known agency within the federal government that funds a lot of vaccine trials. It really lasted only 20 weeks. And the Mayo website that describes this is uscovidplasma.org. And that was set up just a few days after ours was set up. Now, the registry obtained detailed information, including clinical status, mortality, complications on nearly 85,000 patients treated with convalescent plasma from all 50 states. An amazing phenomenon, because we thought we'd get a few hundred, maybe a few thousand patients. It turned out that we enrolled 85,000. Now, the first thing that we published on was safety. You should know that nearly 5 million units of plasma used in the US every year. And convalescent plasma is the same, but it's just donated instead of from this person, it's the person who's just recovered from COVID, has to be asymptomatic for at least 14 days. Some blood banks, I think Leanne will tell you what their rules are, might be longer than that. We don't think that there's virus in the plasma, but we are worried about some of the classical transfusion-related reactions, transfusion-related lung injury, transfusion-associated cardiac overload, other allergic reactions. As you can see, in 20,000 patients, these were rare, very, very rare indeed. 1 in 1,000 had transfusion-related lung injury, maybe 2 in 1,000 cardiac overload. And that's been published in the Mayo Clinic proceedings. Now, does it work? Okay, it's safe. Does it work? Well, there have been 13 published studies that have just done comparisons between patients treated and untreated with CP, not trials, just comparing in their protocol. And these studies varied in how tightly they matched people. You could argue with some of them, but overall mortality was about 29% of patients who did not get convalescent plasma and 19% of those who did. In fact, every paper, every one of those 13 studies had a lower mortality rate in the people who got convalescent plasma. Now, there have also now our ideal, of course, is the, as you know, the randomized trials. 5 randomized trials have been done, most too small to show significant effects. 1 failed to show a reduction in mortality and 4 did. The overall reduction in those 4 to 5 trials was 17% to 13%. But if you took out the 1 trial that didn't show effect, and it was just published in the British Medical Journal, a trial from India, the other 4 showed a reduction of mortality from 21% to 10%. Now, the antibody level in the plasma is the active principle. How much antibody is in that plasma? And we assume that the higher the antibody titer in the plasma, the better the effect on the patient. So what we had to do was to go back, the Mayo group went back to find little samples of the serum from which the plasma was made at the blood bank and have them sent to Mayo for testing. And we were able to contact 56 different blood banks, received more than 3,000 samples of plasma. And now we could ask ourselves, did people in the EAP who got high titer plasma do better than people who didn't? It turns out that there was lower mortality in the people who got really the top 5th of plasma in terms of antibody level than the people who got the bottom 5th. But, and the people in the middle who got kind of medium doses were in between those 2 mortality rates, but it's really, really depended on the patient's condition. To make a quick summary, no effect was found in patients who were treated receiving mechanical ventilation at the time they were treated. But in unventilated patients, we found a mortality rate 40% lower in the people who got high titer plasma than those who got low. And of course, nobody knew at the beginning how much antibody was in the plasma. And these antibody findings combined with safety data is what convinced the FDA to issue their emergency use authorization on August the 23rd, which we thought was long overdue. We thought that the data was good enough a month earlier, but they took a long time to think about it. And then the politics, because the White House showed an interest in convalescent plasma. And we know the FDA Division of Biologics was being very careful to analyze all our data and before they considered this emergency use authorization. And an emergency use authorization is not a licensing. It means that we know that it's safe and it's probably, and the standard for effectiveness might be effective, and there really are not many alternatives. So now, interesting enough, and I hope Jan will talk about this, the FDA required the plasma coming from blood banks to be labeled as to antibody status, high or low. And then the New York Times said that NIH was kind of unhappy about this authorization, and that President Trump called Collins and said that things must be approved by a certain date. And then they did approve it, but a couple of days after the president requested, And everybody made the assumption this was because of White House pressure. And now this is a very critical issue because it's the Division of Biologics which will review the vaccines. Well, we worked very closely with the Division of Biologics and with its director, Peter Marks, for some months, and we unanimously thought that the decision was based on sound science. And so Arturo and I authored a couple of media pieces, the first in Bloomberg News just after the FDA issued their decision defending the FDA, and the second in the Wall Street Journal. This was Arturo's brilliant idea, explaining why the FDA and the NIH might disagree on some scientific issues. So we did these two in the media. FDA made the right call on COVID plasma treatment, which we put in Bloomberg News. And then a second one, a little debate on plasma is healthy. You know, we don't have the definitive information we'd love to have, but we have a lot of good information. On the horizon, we still do not have a single United States published randomized trial of convalescent plasma, 0. Lisan Perovsky at Einstein has got the largest one in the field. It's over 300, and we might have some results in a few weeks. However, Lisan worries that we gave early convalescent plasma in the old days, which was given to a lot of very, very sick people on ventilators who might not benefit. Shmuel Shoham from Johns Hopkins directing a trial of uninfected people at high risk of exposure, like healthcare workers, and he participates in another trial of outpatient mild to moderate illness. And we list all United States trials we know of on our website and give the details of the protocol. Well, I'll sum up. Even absent a large randomized trial, it's hard not to see powerful evidence from a variety of sources of convalescent plasma efficacy in reducing mortality. The data showing the dose-response relationship of antibody levels unknown at the time of treatment to mortality is pretty hard to explain. Got low antibody at a higher mortality, middle, better, higher, best. We know now that early treatment is clearly better than waiting until disease is more severe and complications have ensued. And since I will not make medical recommendations for others, I will simply say, if I were to get COVID-19, I'd want to get high titer convalescent plasma as soon as possible. Thanks very much. Look forward to Leanne's talk and to any questions you might have afterwards.
All right, so Leanne, you are muted, but Dr. Whitekamp, let's see if we can have Dr. Paneth unshare, perhaps.
How do I do that now? It's
perfect.
Oh,
and
good.
I think a host may have stepped in to take care of us. And Dr. Whitekamp, the screen is yours.
All right. Are you seeing my slides?
Yeah,
we are.
All right. Okay, so thank you for inviting me to share the blood bank or blood supplier side of the story. We are fighting COVID-19 with convalescent plasma and have been all year so far. I wanted to just point out, I love this. They either look like tulips or Shrek's little horns on his head, but anyway, they form the corona around the virus, which is why it's called coronavirus. All right, so I just wanted to share with you how, and this is just kind of a graphic of what Dr. Paneth just talked about in this is the months of the year of fear and heroes, let's say. And in January, we weren't really aware of what would, it's trying to make trouble for me. It's going forward and then that, there we go. All right. And then come February, well, we were aware, but we were clueless, like any of you who might remember Scooby-Doo. This is Fred, the clueless sidekick. And then in March, we started recognizing what the impact was going to be on us of this virus. And as Dr. Paneth mentioned, those early days, that's this red area right here where we had to do FDA EINDs. And there was a ton of paperwork for every patient. But once we figured out what we needed to do, we got started pretty quickly. And within about 2 weeks, we were able to do the first donation, and the next day it was out the door. So this blue period here is what was the EAP, that expanded access protocol, which was way easier for people to initiate product for their patients. But as Dr. Panna said, this is for treating severely ill patients. They were in the ICU or on a vent or had life-threatening COVID that was, or disease that was headed in that direction. So just it'll be important later to talk about that patient subset that was used. And again, the MAYO expanded access protocol ended in August 29th, and we're now in this transition period. So this is an area where the FDA will not go forward with any sanctions in terms of this product you can use. You don't need all the paperwork that you had with the EAP. You can provide the product. And a key here is that now hospitalized patients, so instead of having to be as severely ill, all you had to be was, if you were hospitalized, you could get this EUA, or excuse me, the transitional product. It's still an IND product, but it's transitional. And then randomized controlled trials can begin in outpatients, because as you heard from Dr. Paneth, it is important to treat with a convalescent plasma in the earliest phase that you can. And then a big deadline for us in the blood industry is December 1st, where we are to be ready to issue EUA plasma. And I'll talk to you a little bit more about how that is going to work. All right, I just want to make the point that CCP, and I'm going to use that abbreviation, COVID convalescent plasma, is not the be-all, end-all. All it was intended to be was a bridging therapy that we could bring up relatively quickly and help patients as much as we could until the more definitive therapies like drugs, hyperimmune globulin monoclonal antibodies were available, or a preventative was available in terms of a vaccine. It's making me operate it from here. So just the three, this is one of the machines that we use. It's an apheresis machine to collect plasma. What it does is it uses centrifugation to separate the red cells, which are heavier. They go to the bottom and the plasma stays up on the top. We skim off the plasma and send all the red cells back to the donor. So this is the normal, healthy volunteer blood donors that have recovered from COVID-19 and that come into our centers and donate. Now, this is as opposed to the hyperimmune globulin. So this can be direct transfusion to the patient, as opposed to hyperimmune globulin, which is acquired in plasma centers from paid donors. It's a pooled product, and you don't use it for direct transfusion. It goes off for further manufacture and concentration. But the beauty of it is it has a nice standard antibody level, so dosing is much easier. And then monoclonal antibodies, as Dr. Paneth mentioned, is another therapy that's in progress. And one of the things that I found interesting about this is the COVID-19 virus is actually got the largest RNA genome, and it's tricky. It's slippery. It has a very fast replication, and that's a good thing for the virus, because yay, I can make a lot of viruses. But the problem is that you can have more mutations and more recombinations. So that if you made a monoclonal to just one site on that virus, it could slip out from under you, as opposed to what the more effective monoclonals that they're making now have multiple sites. So it would have to really beat the odds to find mutations happening in all those specific sites at the same time. So these the more targets they have, it appears the more effective it will be. And so we know who got the dose of that, but it's looking like it's going to be pretty effective, but it's going to be very expensive. So one of my colleagues in Wisconsin called convalescent plasma poor man's monoclonal. So that's kind of what we're working with right now. Okay, I wanted to mention a couple of things about the virus, just so you can see where we're coming from in looking at the donors. So so this is to try to get you to see about testing. So there's a spike protein, a membrane protein, a nucleocapsid protein, and the SARS, or the CoV-2 virus attaches to the angiotensin converting enzyme 2 receptor on the cell. And yeah, you don't want to go too far in that because that's a very complicated system. But what it does when it binds, it fuses with the membrane, and it actually then gets endocytosed into the cell, and then that membrane opens up and the virus gets into the cell and can start using its machinery to replicate itself. Well, if you're trying, well, two impacts of this. The neutralizing antibody binds to the spike protein and keeps it away from the ACE2, the ACE2 receptor. And we believe that spike protein is one of the targets that we also want to look at when we're testing donors to try to find neutralizing antibody. And by that, I mean antibody that can bind the virus, help it be removed from circulation. And the more virus you have, the more antibody you need to be able to do that. And as has been mentioned, the higher titer plasmas give you greater neutralizing antibody. So we also have to look at symptoms in the donor. And I thought it was kind of interesting. If you think about it, symptoms follow where the ACE2 receptors are. So wherever you have strong expression of the ACE2 receptor is where you're going to see more symptoms. Like, for instance, there's type 2 pneumocytes in the lungs, which the virus loves to live in and gives us, the issues that you have symptom-wise with the lungs, the GI tract, the nausea, vomiting, diarrhea. It can attach to kidney cells. We have acute kidney injury that we see. It loves to excite blood vessels. It binds to the endothelium and from the ACE2 receptors, such that we start having issues with clotting. And that is something that has to be monitored in patients. It hits liver cells, so you have to monitor what's going on in the liver. You'll see in elevated liver function enzymes. It hits the epithelium of your lung, your nose, your mouth. So you're getting that cough, that nasal congestion, the feeling of shortness of breath. And there's even some studies now that are suggesting some involvement with neurologic cells, such that it might explain some of the headache, some of the loss of taste, loss of smell that is seen in some cases. All right, so we have to check we need to be sure that these donors really had COVID. And then we also want to be sure that they made antibodies. So this just kind of shows you the cycle. About a week or so before you have symptoms, that's that phase where you're growing, the virus is replicating and growing in your system, and then it reaches a detectable level, usually around the time you start seeing symptoms. Oh, goodness. And that's, I fortunately have not experienced it, but those who have had nasopharyngeal swabs tell me it's like a brain biopsy. But they just, yeah, Dr. Panlis giving me the nod. And so that, oh, goodness gracious. So that's where the test becomes, where you're likely to be able to see that positivity. And that does drop off over time. And then the first antibody that usually comes in is, 7 to 10 to maybe 14 days afterwards, you start seeing IgM antibodies. And shortly thereafter, IgG antibodies. These are all different subclasses of antibody that come up. And your IgM is your first responder, so to speak, of your inflammatory system, and then the IgG comes in afterwards and usually has a longer lasting presence. Now, we don't know how long these antibodies are going to last. So that's a key question that researchers are working on. But as I mentioned, there's different proteins on the virus, and different tests can look at the different targets. And the ORTHO VITROS total assay looks at the spike protein, but the total means that it looks at all flavors of antibodies. It looks at for the IgM, it looks for the IgG, and it also looks for the IgA, which is in secretions. There's also what's called a nucleocapsid assay that is done, by Roche. And it also is a total assay. So what we're currently doing within Versity is we screen with the Roche nucleocapsid assay, which is a total assay. Then if that assay is positive, we'll reflex it to the ORTHO VITROS total assay. So that's what we're doing right now. And you have to have both to be positive for the plasma to be used as convalescent plasma. Now, the holy grail, according to the FDA, which appears to correlate best in the data that they've received, is the ORTHO VITROS IgG assay. And in a lot of laboratory tests, you have a basic cutoff. And then when a sample is positive, it has a certain signal on their assay. So the signal to cutoff, that's what the S/CO means, needs to be greater than 12 to be or equal to 12 to be a high titer plasma. Now, we have since August 16th been doing screening of all our donors, because we realized that early on we had wonderful referrals of patients from our hospitals that we serve, sending us people who'd recovered and suggesting that they come see us. And as time went on, I don't know if it's COVID fatigue or whatever, we were getting fewer and fewer referrals from the hospital. So we needed to start screening the donor base. So we were screening everybody, whether they were a whole blood donor or an apheresis donor. And this shows you here that our 4 main states that we operate in. Fortunately, we are the lowest of the bunch. So since our positivity rate is about 2.5% in Michigan, 5% in Indiana, 4.5% in Illinois, and 5.5% in Wisconsin. Now, what's in parentheses is what has happened in October. So there's 2.5%. This used to be 3% up until the end of September, and now it's jumped by 2.5 percentage points in Wisconsin, and we know that they are having some significant surge cases right now. So this gives you some sense then that, you know, the October increase was 1.5% for Illinois, 2% for Indiana, and fortunately, you know, we're staying in that lower range with only about 0.5% increase in the month of October. Okay, this is the other instrument that we can use to collect donor plasma. Both of these we can target up to actually 800 mL so that we can get either 3 or 4 products quite often from a donor if they're of large enough size. They get consented. Now, Versity has an IRB approved protocol. And the reason that we did that was so that we could use unlinked data, but we would be able to use the gender, whether they were first-time donors, how many donations they had. So we could use, it was more for that data bank. And so we have to consent the donors to be part of that. We use the standard criteria that we use for regular donors. We also have to do trolley mitigation because that's something that in any kind of plasma that we give, we want to be sure that there aren't any HLA antibodies that could cause a trolley reaction in the patient. So that means that any woman who's ever been pregnant or has been pregnant since, the last time we collected product from her, we have to do HLA antibody testing and make sure that that's negative. We do it by the apheresis technology, as I mentioned, and we do it weekly if the donor is willing, for up to 12 donations. And the reason for the 12 donations is we have to monitor for maximum plasma losses. The plasma loss that's allowed by the FDA criteria is adjusted to the body size of the individual, but we don't want this process to go over that. So we're very careful about that. So in the IND phase, which was the earlier phases, we started out that they had to be symptom-free for 28 days. It was later amended to 14 days. The individual donor had to have a positive molecular test. And originally we had to get a referral from the donor's physician. And later on that got loosened a little bit to their healthcare provider because the doctors were getting a little cranky that they had to sign these forms. And so then their nurse or PA could sign it towards the end of that process. And now we're transitioning over to the EUA plasma, which is where you have to be symptom-free for 14 days. You have to have either a positive PCR test, that's the brain biopsy, nasopharyngeal swab, or 2 approved antibody tests. So it has to be an EUA approved antibody test. And as I mentioned before, the high titer plasmas are going to be designated as 12 and over on their signal to cutoff. And the ones below that from where it's designated as baseline positive, so from 1 to 11 will be low titer plasma. So what does the product look like? This is one of the plasmas, as I said, as has been said previously, it's 200 mLs, but note here, limited by federal law to investigational use, okay? It has to be labeled with that. We do the trolley mitigation, and as Dr. Panis shared with you, it has the same safety profile. I only included standard FFP in mine. I didn't include cryo and other forms of plasma, but there's roughly 3 million, or if you add the other types of plasma, it goes up to the numbers that Dr. Panis was talking about. Because this is a apheresis technology, all those cells are diverted back to the patient or the donor. And even if a stray cell happened to be in that product, this is frozen, so there's no cryoprotectant in there. So these cells just pop if there are any cells in there. So it's strictly the plasma itself. Now, CCP dosing is a ongoing discussion. Some of the protocols and the MAYO protocol initially started out with just 1, but then opened it up to clinical decision-making, whether or not 2 would be appropriate. And so what cases are 2 units appropriate in? If the individual is of larger size, so that if you're under 80 kilos, most people feel that 1 is acceptable. If you're 100 or over, most people feel that 2 units are more appropriate. And then in this no man's land in between here, take into account the status of the patient. Are they an immunosuppressed individual who's going to have more trouble mounting their own active antibody response? Or do they have very high viral loads that they're going to need more product because you need more antibody if you've got more virus? It can be used in pediatrics. There's some studies that are, some smaller ones that are coming out. And you could use, if you were going to use 1 high titer, there may be a point where we might not have a high titer available. So if the individual patient that you're treating has a good enough cardiac situation, then that they could handle the volume in 2 low titers, that would be a reasonable alternative. Okay, here's my sad story for the evening. This is how many units we collected in pink each month throughout the course of the pandemic since we started doing CCP. The line in gold is what's issued. So you can see, we're doing okay up till September. Oh goodness, October has been interesting. You can see what has happened with the issue of convalescent plasma. versus, versus what we're able to collect. Now, part of this is why are collections down? There's pandemic fatigue. There's people concerned as things are surging in their communities. They are less likely to want to come out to donate, even though we do all sorts of wonderful things to protect them in terms of cleaning and making sure everything is safe for them. And, you know, we're just having so many more cases now that we are not meeting the need. And fortunately, New York Blood Center collected a bucket load of plasma early on. And so we've been able to import product from them right now. Last week, we collected, you know, pretty much in our higher levels, about 500 units over the whole organization, but we issued 1,000. So take from that if we were not able to import products from outside our organization, we could run out of convalescent plasma in a couple of days. So, you know, it's really important that if you know someone who has recovered from COVID-19, to ask them to consider donating convalescent plasma, because this is going to become a real issue. And when we hit December 1st, because now everything will have to have those 2 antibody tests, and we'll have to have them properly qualified and tested. Now the test, you know, I told you that IgG test is the one that's the holy grail for doing the titering, or assessing whether or not they're high titer or low titer. And that test is not going to be available to us until November 23rd. So we have 1 week to collect enough to meet the needs starting December 1. So I fear that we're going to be back where we were back here, where we had a very limited product and there was some waiting times for hospitals to get product. So anything you can do to encourage friends, family to donate convalescent plasma, would greatly appreciate that. This is, and I'm not going to go over this one, I just wanted to show you, this is from the study that Dr. Paneth was talking about it, but I thought this graphic really helped out. This is the size of the bar is the number of deaths. And the y-axis is the titer of the plasma. So what they did was they separated out all the patients, or this was the whole group. This was the group that was not intubated. And this group is, you got rid of all the super sick people. They were not the ones over 80 years old. They were not intubated. Oops, they got plasma within the first 3 days of their hospitalization. And what you can see is, first of all, that these green bars, which are the deaths, are shorter than the green bars in the other groups. And that as you increase the titer, you reduce the number of deaths in that population. So that's where that early signal of efficacy for convalescent plasma is coming out. But the point here is, don't get depressed by the studies that come out on what happened before, when you by protocol had to be treating the most ill patients. That is not the sweet spot for convalescent plasma. The sweet spot for convalescent plasma is early, is within 3 days of being hospitalized. And it may even be better in an outpatient setting. We don't know that yet. And we don't have the studies for that yet. So again, just to remind you, this is a bridging therapy, not the be all end all. The jury's still out on CCP. And maybe the jury is saying, yeah, it's good, but what circumstances are we going to use it in? I just want to remind everybody that if the public health emergency is canceled, okay, if HHS cancels the public health emergency, we have to, at that moment in time, stop issuing convalescent plasma because the EUA no longer applies. So in summary, okay, so for the geeks, the science geeks, this is a little antibody that's being the knight that's riding in. But anyway, the take home messages: use high titer CCP, use enough, use it early, and learn from this. Learn how to have your disaster plans, be ready for equipment, software materials, for cleaning supplies, gloves, masks. Be ready, because you need to be ready for that next virus. Okay, thank you for the
Yeah, that's wonderful. Yes, I mean the way screens usually work, or these things usually work, there would be applause, but right now we just have screen happiness. So thank you so much, Leanne and Nigel. And this is a great time for us to open it up to questions. You can put a question in the chat, or you should be able to raise your hand and put in a question. I guess while we're waiting for one, I'd ask each of you: are you generally optimistic about the plasma, the use of plasma in this pandemic, or do you think, well, maybe it won't quite turn out as to be, we won't have enough, or it will be difficult for us to use? How are you thinking about the sort of total place of convalescent plasma in the pandemic?
I'll let Leanne go first, and I'll weigh in.
I'm actually optimistic now that it's being targeted to a more better towards that sweet spot for convalescent plasma. But I am very hopeful that I and my CCP services won't be needed for that much longer. That, other alternative therapies, off-the-shelf therapies where you can hopefully develop a storehouse of them that will be available. Like I said, this is bridging, and I'm going to do my darndest to make sure that the convalescent plasma is available during this bridge period. But I do say I will breathe a sigh of relief when we're out of the need for it.
Yeah, I agree. And I was really happy to see how much on the same page Leanne and I are about all of the nature of the evidence and the usefulness. I think that, it was emphasized by Leanne, and I did not, I wanted to mention it. It is an inexpensive product compared to many medical products. Nobody's making a big amount of money on it. There's no big pharma behind it. Every unit of plasma comes from a volunteer. The people who go to the plasma companies, their plasma cannot be used directly in people. It's used for fractionation to make products. But if you have to go to a blood bank, it's a donation. That's been historically the way things are done: red cells and plasma together. So I think it's because it's not expensive, and because we're learning right now to use it early. If we can get a good supply, it can be used in places that don't have many resources. That can't purchase monoclonals in India and South Africa and so forth. Because monoclonals, as Leanne was saying, and it costs a lot. Remdesivir is priced at $6,000 a treatment. Hopefully hyperimmune globulins will be low priced too. God knows where the vaccines will be. But until we have a vaccine, and it's going to take a while for that to be distributed, antibody therapies of some sort are probably as good as we have.
So Leanne had a slide there at the end about the next virus. So we round the bend someday and come out on the other side of this pandemic. What kind of infrastructure should we be putting into place so that when there is another pandemic, we could more quickly utilize convalescent plasma and bring it to bear sooner? You have a sense of something like that?
Well, I do know that the United States had a pandemic plan under the Obama administration that was kind of discarded, and the committee or group of people who were supposed to handle those problems were disbanded. And I do think that a lot of thinking has gone on to how we handle the next viral emergency. After SARS-1 came through a few years ago, people thought about it seriously, and it has been thought about. I think we just have to bring that plan up and distribute it and work on it. Perhaps the next administration will be able to do that because it is there. There is a plan. And I think, you know, we're in a difficult position. The last decade or two has seen so many viruses coming from largely the animal world.
Mm-hmm.
We introduce ourselves into the universe of pangolins. Why do we do pangolins? Why do we do bats? You know, and we get it. We press against these boundaries, and then we're shocked. Oh my God! One of the bat virus or pangolin virus gets into us and starts killing us. We gotta stop that. That's, you know, it's human behavior at the root of it. Sorry to say.
Right. I'm going to let you guys have a chance because we have reached time. Any closing thoughts that you want to make sure that you have for folks?
Well, people have a couple of
Are there?
chat questions. Can you get CCP at any hospital? I'll leave that to Leanne to answer.
Yeah, most, if not all hospitals have a blood supplier, and the blood suppliers will provide product for that hospital. So, you know, supplies vary over time, but, you know, it's there.
And another question I think you might be able to answer is, how long can someone donate plasma? Will antibody last long enough so that a few weeks later you can still give?
Interestingly, I made the assumption, and you know what that does to you, that perhaps some of these community-derived donors, as opposed to the hospital-referred donors, might have lesser antibody levels. But we're actually seeing when, you know, about 500 was the signal to cutoff average in the early hospital referral phases. And they're about 1,000 right now in general in the people that we're seeing. And they're holding on for those 12 weeks. What's going to happen after that? Would that be enough antibody to prevent you from getting infected? We don't know.
Yeah.
And my leaving thought, if I may, is that if you know anybody that has recovered from COVID-19 and remotely would like to donate plasma, you know, we have great cookies and juice if you want to come see us.
I wonder if some of those people who get COVID in the White House might be willing to contribute precious plasma to us poor, simple folks in the real world out there. Wouldn't that be nice?
Yes. You're supposed to be able to give a coherent history though, so yeah.
All right. Well then, so I really appreciate both Dr. Weidekamp and Dr. Paneth for spending their evening with us, for sharing their expertise, and for their great work on this really important project and service for the nation and our region. And I just want to thank you guys so much for all that you do and for sharing your time with us.
Appreciate you having us.
Thanks, and that's so great to hear, Leanne, about your work in Grand Rapids and Versity. And it's I was amazed at the number of units you have given. Thousands and thousands of units. Fantastic.
Yep.
So
great. Yep.
I want to thank Mark Brevy. I want to thank Nikki Lechner for helping put this together. I want to thank all of you for joining us today. I hope you have a safe trip back to the kitchen, and take care of yourself. Wear your mask. Socially and spatially distance from other people, and wash your hands. And thank you for joining the College of Human Medicine this evening. Good night, everybody.
Thanks, Aaron. Good night.
Thank you.